So today we are going to talk about a very important topic, that is insulin therapy in diabetes. So we'll read this topic under these headings: glycemic targets, insulin preparations, insulin injection technique, insulin regimens, methods of insulin administration, and insulin therapy in type 1 diabetes and type 2 diabetes. So let's take up glycemic targets first. So according to ADA guidelines, the target HbA1c, these glycemic targets I am telling you in adults, in non-pregnant adult population, the HbA1c should be less than 7%, and this is the most important glycemic target. If I talk about the preprandial capillary plasma glucose, so that would be 80 to 130 milligram per deciliter. And postprandial capillary plasma glucose, it should be less than 180 milligram per deciliter. This is as far as non-pregnant adult population is concerned. Now, the higher HbA1c target, is acceptable in selected populations, like across all pediatric age groups. In healthy older adults, the target HbA1c of less than 7.5% is acceptable. And in group of population who have history of severe hypoglycemia or hypoglycemia unawareness, or group of people who have limited life expectancy, comorbid conditions, advanced microvascular and macrovascular complications, the HbA1c target of less than 8 to 8.5% is reasonable. So in group of population who have high risk of going into hypoglycemia, like who are already a history of severe hypoglycemia, or who are having hypoglycemia awareness, or older patients with poor health who have limited life expectancy, or in population who have advanced micro or macrovascular complications of diabetes, like advanced cardiovascular disease. Okay, so in that population, the HbA1c of less than 8 to 8.5% is very much reasonable. So this is about the glycemic targets. So now we will talk about the different insulin preparations. We broadly classify it into conventional insulin and insulin analogs. Conventional insulins are basically human insulin formed by recombinant DNA technology. So they are recombinant human insulin. It includes regular insulin, also known as actrapid, NPH, neutral protamine heptone insulin, and also I will consider here Afrezza. Afrezza, it is a type of inhaled insulin. It's a dry powder formulation of recombinant regular insulin. So these are conventional insulin. And what are insulin analogs? Insulin analogs, they are basically derived from the natural insulin, but the amino acid sequence is altered to make them more physiological, right? So the amino acid sequence is altered in the insulin to create insulin which act more physiologically. So these are insulin analogs. They are basically of two types. One is rapid acting and one is long acting. So rapid acting include insulin lispro, insulin aspart, insulin glulicin. These are rapid acting. And long acting includes detemir, glargine, and a recent one, degludec, which is the longest acting. So if asked which is the longest acting insulin, that is degludec. It has duration of action of 48 hours. Glargine has duration of action of 20 to 24 hours. Detemir has a duration of action of say 16 to 20 hours. And here if I talk, so this is again short acting insulin. This regular insulin is short acting. NPH is intermediate to long acting. And this Afreeza, the inhaled form of insulin, is again rapid acting or short acting insulin. So this is about the insulin preparations. Now we will talk about the combination insulin preparations. Before I talk about the combination insulin preparations, I want to tell you what are the advantages of these insulin analogs over conventional insulin. These insulin analogs, they act more physiologically, that as I have told you. So there is decreased risk of hypoglycemia. Okay. These rapid, if I talk about this rapid acting insulin, how are they better than this regular insulin? It is again rapid acting, but they correlate more to the physiological peak of insulin after meal. Okay, so they are short acting, they have early peak than regular insulin. So that's why there is decreased risk of hypoglycemia. So that's why it is being recommended that in type 1 diabetes patient, rapid acting insulin analog should be preferred over regular insulin. But when we talk about the type 2 diabetes, there is no much difference in risk of hypoglycemia or HbA1c reduction. So both can be used. But in type 1 diabetes specific rapid acting analogs, they should be preferred because there is decreased risk of hypoglycemia. Another advantage of these insulin analogs is that their action is, their peak or their action is independent of the dose and the site of injection. But when we talk about this conventional insulin, so depending upon where you are injecting, whether you are injecting in thigh or you are injecting in abdomen, they have variable absorption profile, right? So these are the advantages. Now when I talk about the long acting insulin, again this detemir, glargine, degludec, they have decreased risk of hypoglycemia in comparison to NPH. So that's why overall these insulin analogs are better than the conventional insulin preparations. Now we'll talk about the insulin combinations. So it includes the NPH plus, these are pre-mixed insulin combination. It includes NPH plus regular insulin. It could be in a 70-30 ratio, 70% NPH and 30% regular insulin, or 50-50 ratio. It is also called as mixed start insulin. Then we have rapid acting analog like insulin lispro, insulin aspart, insulin glulicin, plus protaminated form of these rapid acting insulin. Example, lispro plus protaminated lispro. So that it becomes long acting. So these are the insulin combinations. Apart from that, we have one drug, injectable therapy known as Rhizotec. It includes insulin degludec plus insulin aspart. So a single daily injection is required. Now let me tell you about the combination injectable therapy. That means insulin plus GLP-1 receptor agonist. So the two common one is Zoltoffi, other one is Soliqua. Zoltoffi, it includes insulin degludec plus liraglutide, and Soliq includes insulin glargine per plus lexisenatide. So again, single daily injection is required. So these are few new injectable drug therapy for the treatment of diabetes. So now we'll talk about the insulin injection technique. So what is the route of insulin injection? It is subcutaneous. And mind you, intramuscular injection should be avoided. Because intramuscular, there is erratic absorption. The absorption of insulin, it depends upon the activity of the muscle. So there is increased risk of hypoglycemia or hyperglycemia. So subcutaneous route should be preferred. So for that, what you have to do, you have to inject at 90° to the surface, right? In very thin individuals or in small children, it may be given at 45°, but otherwise it should be injected at 90° to the surface. Now, what are the sites of insulin injection? You can inject it on the abdomen, but remember 2 inch around the navel, around the umbilicus, avoid to inject. Then we can have it in buttocks, in the pocket area, okay, in the back pocket area, upper thigh, particularly 4 inch below the top of the lower limb and 4 inch above the knee, and upper arm in the deltoid region. These are the classical sites of insulin injection. Another important thing you should remember is side rotation. Supposingly you are injecting it on the abdomen, so keep rotating the side. If you are injecting it on the deltoid, keep rotating the side. Don't inject at the same site again and again. Why? Because of the adipogenic action of insulin, there is accumulation of subcutaneous fat, which is called as lipohypertrophy. And if you inject through it, there will be again erratic absorption, again there will be risk of hypoglycemia. So it is one of the recommendation that you should assess the site for lipohypertrophy, and if you find, so do not inject at sites of lipohypertrophy. And to prevent lipohypertrophy, you have to keep rotating the site. Okay, it's not like you one day you inject it on abdomen, another day on buttocks, not like that. But on the abdomen itself, you keep rotating the site, and buttocks itself you keep rotating the site. This is what I want to tell you. So site rotation is very important to prevent lipohypertrophy. Now few frequently asked questions is that whether you need to clean the surface. No, it is not required unless it is reasonably clean. Okay, but if it is visibly soiled surface, then you can clean it with isopropyl alcohol, especially in hospital settings. Okay, when there is lot of risk of infection, so you can clean it with isopropyl alcohol, then allow the alcohol to dry, then inject. And when you inject the insulin, keep it for 5 seconds, count 1 to 10, and then you can withdraw it. Okay, and whether you need to pinch, no, you need not to pinch also. Okay, so these are the few things you need to know about the insulin injection technique. And one important recommendation is that you have to use the shortest needles. Like if you use the pen, 4 mm needle. If you are using the syringes, 6 mm needle, because they are less painful and they are safe, they are effective, so they should be the first choice, shorter needles. Another important question is, like, if you have not used a vial, you can keep it in a refrigerator. But once you have opened it, you need not to keep it in refrigerator back. You can keep it at a room temperature out of direct sunlight, because it would, if you keep it in a refrigerator, it would be rather more painful. Okay, and if a vial is freezed, you have to discard it. If there is a clumping, if there is a clouding of the insulin, you have to discard it. Okay, so these are the few things you need to know about the insulin injection technique. So what are the methods of insulin administration? Syringes and needles. This is one of the methods. So syringes are of 0.3 ml, 0.5 ml, 1 ml, and needles are also of varying sizes like 6 mm, 8 mm, 12.7 mm. So you should try to use the shortest needle of 6 mm because it is less painful, safe and effective. And one important thing is ki when you open the vial, so try to clean the top of the vial with isopropyl alcohol and roll the vial between your hands. Do not shake it. Okay, and that I have told you, can you keep it in a refrigerator unless you haven't opened it. Once you have opened it, you need not to keep it in a refrigerator. Keep it at room temperature out of direct sunlight. So this is about the syringes and needles. Other method of injection is pens. So insulin pens are available, both reusable or pre-filled disposable pens. So in reusable pens, you can put the cartridges again and again, so you can reuse it. What about the syringes? Can you reuse it? Ideally, they should not be reused, but if you want to, then recap the needle immediately after use. Okay, and if it is visibly deformed, so discard the needle. And if about the pens, we have reusable and pre-filled disposable pens. And third technique is insulin pumps. So insulin pumps which delivers continuous subcutaneous insulin infusion, they are also available, but they are very costly. So these are the methods of insulin administration. So now we'll talk about the insulin regimens. So first is basal insulin. In this we give a long acting insulin usually at night. Okay, so that usually provides the 24-hour coverage for the basal insulin, right? Then we have basal plus. In this, apart from basal insulin, we give a parenteral insulin with the largest meal. So in basal insulin, we give long acting insulin, usually at night, to cover for the basal insulin requirement in the body. In basal plus, we give basal insulin plus parenteral insulin with the largest meal. So 2 injections a day. Then we have basal plus 2, in which we give basal insulin plus parenteral insulin with 2 major meals. Supposingly some people used to take only meals only twice a day, so this is a good one for them, right? And the third one is basal bolus. So in basal bolus, again we give basal insulin plus parenteral insulin with each of the 3 meals. So that means 4 times you have to give insulin a day. Then we have what we call as split insulin regimen or self-mixed regimen. So in this we used to mix the long acting insulin with rapid acting insulin. So usually NPH. NPH, it can be mixed with any of the rapid acting insulin analogs, but you cannot mix insulin glargine or datamir or degludec with the these rapid acting analogs. So in this we mix NPH and the rapid acting analogs, so we can adjust their dose independently. These could be rapid acting analogs or regular insulin. And let me tell you, there are few recommendations about this, that don't keep insulin as a mixture. Okay, do not store insulin as a mixture. When you want to inject, immediately before that you mix the insulins. Okay. And another one is pre-mixed insulin. Like I've already told you, like 70-30 combination or 50-50 combination, like 70% NPH, 30% regular insulin, or 50% NPH, 50% regular insulin, as 70% protamine lispro plus 30% lispro. So these are the pre-mixed insulin. These are the basic insulin regimens. Okay.